So just talking about commercial insurance now, commercial, not government insurance, commercial insurance. Here's the problem. You've got a system where employers were paying for insurance for people, and employers were shopping the market, and there was some element of free enterprise at work. Now you got the government in the act telling people, this is what you got to have, this is what you've got to do, this. It's created all kinds of problems with employers. It's somewhat destabilized the health insurance market, okay? And effectively what's happening now is that the government will start controlling your commercial insurance. It is actually controlling commercial insurance now, just like it does your government-sponsored insurance. And government-sponsored insurance, of course, is Medicare and Medicaid, okay? And so, again, back to the commercial market. In the business I was in, when I worked for the physician group, I ran a physician group of about 900 doctors. One of the things that we were always trying to do, because we were being incentivized to do it, is to change the way doctors practice medicine. So let me give you an example. Now, there's a couple good things in the Affordable Care Act. So one of the things that actually was pushed by Bush, got into the act, is something called accountable care organizations, okay? An accountable care organization is a group of doctors that come together and they say, we are going to be accountable for the care of a population of patients. And by accountable, what the government is saying to them, and this is in the Medicare program, what the government is saying to them is, we will designate to you X number of patients that we believe are your patients. They run these statistics based upon claims, et cetera. And they say, okay, this is your panel of patients. So the group that I was involved with, we created an accountable care organization under the law. We took about 260 of our 900 doctors that wanted to participate, and we formed this new group. It was called Southeast Michigan Accountable Care. And as a consequence of forming that group, we had 15,000 Medicare patients assigned to our group, and a budget, what was it, like $260 or $70 million a year. So we had to watch over $260 or $70 million of healthcare spend, okay? Now, just think about that. That's kind of a free enterprise thought process, right? Because all of a sudden, somebody's watching the money. You know, somebody who has a vested interest, because the people who have the card, who go in and say, here's my card, I mean, they're not necessarily watching the money because they don't have to pay for it, okay? So what the government said to the doctors is, for that patient population that you have, if in fact you save money, we will split the savings with you 50-50. The group that I started, and I left when they got their final numbers, but I was there the year and a half for the first performance year. Our first performance year, we saved $24 million. Now, that's not a lot of money, but it's $12 million to the docs. So when you write a doctor a check for $93,000 as a bonus for their practice for that year, you can affect their behavior, you see. Sure. And that's like the beauty. It's exactly what it's all about. And think about it. We're not adding new money in the system, right? We're just taking the existing money and reprioritizing it. And we're taking that money and we're saying, this is what we're spending now. And so what we're going to do is we're going to reprioritize that, and we're going to come out with programs and say, if you meet these certain measures in terms of quality, and when we talk about quality, what we talk about is this whole concept of getting away from episodic care. I'm coughing. I'm in your exam room. Okay, take this medicine, come back and see me in a week if you stop coughing. But by the way, you never asked me about my diabetic situation. You never asked me about HbA1c or my LDL-C, or did I have my foot exam or my eye exam. You didn't ask me those questions. Why? Because the doctor's got 20 exam rooms lined up, not 20, but 4 or 5 with patients, racked and stacked. So what are we trying to do? We're trying to get to the doctors and say, no, you have to practice holistic medicine, patient-centered medicine, we call it, where you look at the entire person. So, if there's a woman that comes in, I remember talking to Dr. Leon, she practices downriver. And she's the kind of doctor that you want to be working in this system now, because she was talking about how hard it is to get some of her patients. She just said, when I just had a patient the other day, and when the lady came in, I just noticed, we pulled up her chart. I know she hadn't had a pap smear. I'm like, we can do that right now. I'm not going to reschedule it. I'm going to do it right this minute. So it's a cervical cancer detection test, okay? But that's what the doctors need to be doing. We need to be changing away from this fee-for-service model to an incentive-based model where we pay for value. Okay, and that's one of the things that's actually part of the Affordable Care Act through that accountable care program, is this whole concept of moving away from fee-for-service to paying for value. But now remember I said about the boat that's leaking? Wouldn't it have been nice to get this system going like 4, 5, 6, 7, 8 years down the road and then start adding more people into the system? No, we're adding people before we're even at the value paid. We're adding people before doctors have been able to, are able to connect. For example, there are some electronic devices that we could effectively use in practices. If you are what we call a chronic condition person, let's say you've got COPD, right? So if we add into your practice a device, what we call a medical registry, and what that registry does is that when you come in the office, it knows who you are, it knows the last time you had a certain test, and it flags you to the doctor. So when the doctor walks into his exam room, the first thing that's on top of your chart is a list of things saying what you haven't had done. And then immediately he starts ordering these things or asks you about them, what's going on. Again, it's a holistic approach. Things haven't been done that way in the past. Now, things are moving very quickly that way because all of a sudden all the health plans are on board with that, the employers are on board with that, everybody's pushing to get away from fee-for-service. You get paid for an office visit, you get paid $68.75 or whatever the number is. You do get a payment, but you're not going to get a raise in your payment. You have no chance of getting a bonus unless your diabetic patients all have an LDL-C average level of 8. All right? So guess what? If they don't, your buddy down the street who's practicing medicine that does is going to get that $100,000 bonus payment. And a $100,000 bonus payment is a huge amount of money for a private practitioner practicing primary care medicine. Okay? So it's these types of things that are taking place in healthcare. You don't hear about them a lot, but they're out there and they are taking place. The problem is that we can't plug those holes fast enough as we're adding people in the system. Healthy Michigan, the Medicaid expansion in Michigan. We've added over 630,000 people to the Medicaid rolls by Healthy Michigan. Expanding, that's a lot of people. Expanding that program, adding 630,000 new faces in this delivery system. Again, into a system that is in the process of trying to be transformed. But just imagine what it would be like to have someone come into your house, completely change your ranch home into a 2-story, your 1,000-foot ranch home into a 2,000 or 3,000-foot colonial, and you're living in it at the same time. And everything, you got workmen everywhere, and you're trying to function, and everything's happening all at once. And that's kind of what I like to describe as happening, is there's just too much activity taking place, and not enough coordination of activity. And the political players are pushing. Providers responded. The hospitals were very happy because they're getting money for what was otherwise uncompensated care. So they're very excited about that. And because the primary care physicians are getting paid at Medicare rates, that was part of the Affordable Care Act, pay Medicare rates for a Medicaid office visit. So before, in the parlance of healthcare, a 99213 is an office visit code. That's the most common code billed, 99213, 99214. Those are the most common codes billed in healthcare. That's the code that a physician bills when they see you in their office. Medicare was paying, they're probably paying like $73, $74 for an office visit. And by the way, when I was working for the group and doing the contracts, I would negotiate our contracts based upon Medicare. Now, isn't that kind of weird? Because you would think that the biggest buyer of health insurance should be buying it at a cheaper rate.
Sure.
But if I could get a 100% Medicare contract for my doctors, man, that's great. Medicare was a benchmark. And you would think that Medicare, being the biggest purchaser, should be getting a great discount, but that's not the case. Not the case at all. So where Medicare was paying $72, Medicaid was paying like $28 for the same office visit. Yeah. Well, after Obamacare, now they're paying the full $72 for the same office visit. Now that's supposed to phase out, and the states are kind of supposed to maybe kick in, but where are we going to get the money for that? And we'll get it from the roads. The fact of the matter is, though, but that was the whole incentive to get the PCP. You asked the question, well, how do the providers feel about this? Yeah. Well, that was the whole incentive to say to the docs, we want you to see all these patients because we're going to pay you more money to do it. But think of the expense that you just created by adding in all of that extra patient load on top of like almost tripling the fee that they're getting. They weren't unhappy with it, and they weren't turning it away, and because they're getting paid a good fee to see these patients, and there's a big bulk of patients. So again, just from the quality side of things, we've got a long way to go. We really do. And just so you understand this, and I know you've heard numbers like this, but the fact of the matter is, in Medicaid, just using Medicaid, this is very similar to Medicare. 5% of the patients in Medicaid account for 50% of the costs. 5%, 50%. 1% of the costliest 1% account for 25% of the costs. 1%. So what does that tell you? That tells you there's something wrong, right? That tells you that we're waiting to treat people till they get to the point where now we're treating them with very expensive measures. We're not doing things to proactively try to stop serious situations from developing. If somebody has hypertension, if they have hypertension and they have a history of diabetes in the family, but they don't quite have diabetes, but their markers are moving up, and they have hypertension, you know what? It's a pretty good guess. And there's actually computer programs that are really good at this, doing predictive modeling. You plug in all the claims data, and that computer program will pick out the people that are likely to end up on dialysis. And once someone's on dialysis, let me tell you, first of all, they don't get off. It's just a constant road, and it leads to all kinds of other issues, and it's very expensive, and it's just a road to extremely high costs. Just read an article the other day that I think maybe it's Burwell, or if it's not him, it's someone else in CMS, or a former CMS official. They're starting to rethink these cancer drugs. They're basically saying, are we really getting the value? There are some injectables that we spend $20,000 for on administration. They're just ridiculous amounts of money. And is it really, objectively, is it really extending life? Is it really, is it really prolonging a person's life? Is it sending the cancer into remission? And there's test studies that will show, if you get pancreatic cancer, let's take one of the worst, and you aggressively treat it, and you do nothing, you're going to live about the same period of time. But most people are going to say, I want everything you can do for me. And part of that reason is because they don't have to open their wallet and say, how much money do I have? What can I afford? Okay? And then you get into all these other medical, social, philosophical, ethical issues. Who decides what treatments should be available? Who decides what treatments shouldn't be available? So that's a whole other subject. Well, you don't want him to. Yeah. Well, I don't know that he does well. He may through his HHS director and others, but you could effectively have death. In other countries, they will not give certain drugs that we will give to people here. But then, if I brought all that information in here and we sat down and we looked at that and we were trying to make a business decision, we would probably come to the conclusion we ought not be spending money on a lot of these chemotherapy drugs. Now, the end result of that is, guess what's going to happen? People are going to die.
They're going to die.
They're going to die. But they're going to die anyway.
They want to. They want that. They want to get the people out.
Well, but the question ultimately becomes, let's not take cancer, but let's take someone who's got a treatable disease condition. Let's take someone who's got COPD and continues to smoke, okay? And people do that kind of stuff. I used to laugh driving down Oakwood Boulevard and you see all the people with their, on Michigan and, Oakwood and Southfield, you'd see all the people with their little IV things smoking cigarettes, because when they ban smoking in the hospital, they wheel those things out there and they'd be, seriously, it's like, what is going on? What are you doing? Well, do you tell those people, hey, you can have all the treatment you want, you just got to pay for it, or you got to buy your own catastrophic insurance and pay for it? I don't know what the answer is, but I can tell you, we're going to have to address that sooner or later. Because as we talk about quality and trying to get doctors to intervene earlier and have wellness programs in place to try to address these issues before they develop, that's really the best way. But here's the problem, and this is the bad thing in healthcare. We're focused on now because we can't really afford what we're doing now. So when I was running that network, and we'd have a meeting with HAP officials, Health Alliance Plan people, they would come and say, you're not doing as well as you should on this quality thing. You're not doing as well as you should on that quality thing. You're not doing, we'd like you to improve on that. But then they look at our financials and they say, but you're doing really good on imaging. You're doing really good on this. You're really doing good on keeping the money down, or the spend down. And so therefore, they were kind of willing to overlook the long-term measures, because in the short term, we were keeping the spend below the benchmark. Let's say they had a spend for us of $230 per patient per month, and we were keeping it at like $218 or $220. We were heroes, even though we weren't meeting our benchmarks. Let's say for 70% of our diabetics to have an LDL-C under 8 or an HbA1c under 8, right? That they didn't like that, but as long as we kept the money in check, we were okay.